So welcome to DSMSpeakEasy episode 2. This is our second get-together, and it takes an old dog a long time to learn new tricks. So this is the second week that I forgot to press the record button. So I'm going to share with you the slides that we used as fodder to discuss the rest of the session. Unfortunately, we don't have any of the recording of the session, but this is the type of information we were talking about today. So to start off, I'd like to just take a moment to acknowledge our sponsors and thank them for their support and all the good work they do in providing us the tools of the trade and all the fabulous appliances that we get to use in helping our patients manage their snoring and sleep apnea. So DSMSpeakEasy, just like being here, except you're not, looking for that silver lining. Today's topic is predicting OSA oral appliance success. So some of the evidence in the literature we reviewed before our discussion, which was actually very enlightening, unfortunately not recorded, factors influencing oral appliance therapy outcomes. Notice I'm not saying predicting. It's important that we realize that when we talk about the fact that females respond better than males, lower age, better outcomes than a higher age, lower BMI, smaller neck circumference, lower baseline AHI, supine-dependent apnea seems to respond better. Primary area collapse being behind the tongue rather than behind the soft palate seems to respond better. All sorts of cephalometric measurements and actual visualizations of the airway either in DICE or not in DICE. Doing Mueller maneuver and so forth. Even single night sleep studies are not predictive of oral appliance therapy. That data that you get even with an overnight sleep study can influence your decision, but nothing is predictive. All of these factors will play a role perhaps in your decision making, but none of them you can hang your hat on 100% that it'll determine that an oral appliance will work. Now, we've all heard about the different physiological and non-physiological factors. The negative pressure which the airway collapses, the muscle responsiveness, the arousal threshold for that particular patient, and the whole respiratory system, the loop gain, that it varies from patient to patient. All of these play a role in influencing whether somebody's going to respond to an oral appliance or not. When we look at different predictors, Kuno did that for us in 2016, what he found that regarding specificity and negative predictive value, the RCMP, remote control mandibular positioner, actually scored the best. The only other technique that scored well was the multi-sensor, but this is good in research, not something that you can do in clinical practice. You're not going to insert a catheter and have multiple sensors at different areas of the airway to evaluate pressure when you're just doing an overnight sleep test. It's just not going to happen. So, two devices I'm going to talk about and just lay it out there because there's very little in the literature about real evidence about official prediction of OSA resolution with oral appliance therapy. Okay, the Apnea Guard is a device that's been around for several years. I never really paid much attention to it in the early years, but ever since it's been reimagined, removing the walls, allowing us to use it as a bite registration tool and then scan the bite, send the bite away to the lab to manufacture an appliance with the scanned images, have the patient wear the device while they're waiting for their appliance to be made. They can advance their device based on resolution of symptoms. And when the actual custom appliance comes back from the lab, they can then deliver the appliance based on the amount that they've advanced their Apnea Guard. So if during that interim period, they've advanced themselves 3-4 millimeters, you can do that immediately to the custom appliance and without missing a beat. It's as if you initiated therapy the day you took impressions. And I got excited about this. And I've been using this technique since December. And number's too small to really make valid statements about it, but It's looking good right now. Once I get more patients done, I'm gonna have some more specific things to talk about. So the theragnostic protocols based on the following studies. Most males, are determined to establish better outcomes, better results with a higher VDO, higher vertical dimension opening. Interesting. 70% of maximum protrusion may provide immediate temporary benefit. That was a conclusion they came to in this study because they found that 70% max protrusion was found to be within 1 millimeter of 80% for 80% of the patients of optimum position. Okay. Odds of responding to a custom oral appliance increased 3.4-fold if they first responded to an apnea guard, and odds of HI being brought down to below 10 with a custom oral appliance increased 4-fold if the apnea guard brought the HI down to below 10. None of this is predictive of oral appliance success, but gives you insights. The theragnostic protocol basically is to optimize outcomes using evidence-based selection of vertical, protrusive, and bite, provide immediate therapeutic benefit while patient is waiting for the custom oral appliance, and reduce overall chair time and office visits needed to successfully titrate a custom oral appliance. Identify oral appliance therapy responders using a trial oral appliance, of course, coupled up with some type of a steep test. First, select the vertical. Low, medium, high. There's 3 tray heights. And of course, the tray heights are related to male, female, large scallop tongue versus non-large scallop tongue. And then step 2, deliver the apnea guard using some polyvinyl putty. Step 3 is determine what 70%, which would become the target setting, habitual posture till full protrusive. Now, the beautiful thing here is that you have a tremendous amount of flexibility. The apnea guard, if you like to start very conservatively with your position, which is what I do, you can do that and work towards 70% protrusion or resolution of symptoms. Or if you're someone that likes to have a number to start with, you can start at 70%, 60% protrusion, move forward after wearing it for a week, all the while they're waiting for their custom appliance to be made. So there's a tremendous amount of flexibility built into the system. You don't have to do it one way or another. And you can actually custom tailor the approach based on the patient in front of you. Okay. The net result is higher probability that the custom appliance is delivered at target or as close to target protrusive as possible. Here is an example of an apnea guard used to take a bite registration, then was worn while this this DSAT appliance was being fabricated, and the appliance was delivered at the position the patient returned to in the apnea guard after waiting for about 2.5 weeks for that appointment. Matrix Plus. Okay. Similar, there's an upper and lower tray. There is not an option of different verticals here. The VOD on this is probably 5 or 6 mils. Polyvinyl materials used to line the tray. And you take a range, full retrusive all the way to full protrusive and habitual value. All 3 of these numbers are registered. Now, the matrix algorithm was developed using random forest machine learning to evaluate binary outcomes for about 266 features. So there's 266 decision trees that vote yay or nay that an appliance will work for this patient. This information, along with the outcomes from that static or the final study as part of the theragnostic series of studies, are used to determine whether therapeutic success would be anticipated and also determine the optimum protrusion position. Now, Zephyr is continuously working on upping the game and make it more accurate. So at this point, I'm sure there are more than 266 features, but this is the number that was used to actually validate the product in their original research. Matrix Plus system for the theragnostic study is a multi-night study Patients wearing the trays with a remote control unit that forward, back all night long. In the first night of the study, it's actually doing that, and it's moving the mandible in 0.2 millimeter increments and trying to establish the optimum position based on the decision trees and the machine learning, and based on oximetry and respiration and so forth. Okay. Then there's a second night. This is a static study where the remote control unit takes the jaw to the optimum position established in the first night. And there it stays pretty well all night, but it's testing the waters. It's moving up and down, fine-tuning, but in very small increments. It knows pretty well the area it needs to be in. There are times when it can make a final decision after the second night, and there are times when it'll ask the patient to do a third night to finalize things. In the end, you end up with 8 scalable channels at 10-second to 8-hour windows. You actually take a look at this raw data. It's available to either the physician or the dentist. Okay. The good news is that if the Matrix Plus says they're a responder, you can proceed with confidence. Predicted success, 67 therapeutic success, 2 therapeutic failures. And those 2 that were therapeutic failures according to the criteria of the Matrix Plus outcome, which is an ODI of less than 10, would have been clinically successful because they were close to that mark. The issue is that in a research setting, you either make the grade or you don't. So it has a positive predictive value of 97.1%. The saturation is normalized, insight, RE, optimum protrusion, and even if they end up saying it'll work and it doesn't, in a clinical world, they'll be close enough so you can proceed with confidence. Okay. This is a patient that presented with a BMI 41.9, overall apnea-hypopnea index of 139, supine 171, non-supine 118. Asked me, will an appliance work for me? Well, how do I answer this question with a clear conscience? I suggested let's do a Matrix Plus. We did. And you can see he's at the borderline between yellow and green, but he was labeled a responder. And the protrusive range, 95% of his full protrusive. So he was advanced practically the whole way. I made him a dream tap. Took him almost 2 months to get to the optimum position. Once he was there, we sent him home with an HST. Overall, he got down to 2.5 events per hour. Apnea-hypopnea index. And you can see the range on his back, 2.5, and his left side, 2.1, right side, 3.1. Now, after rubbing my eyes, I said, listen, can you take this Knox T3 home again and do 2 consecutive nights? So I got 2 more studies just to check. And you can see the range. He started 2.5 the first study, 2.9 the second study, 2.2 the third study, with very little variation. In all sleep positions, he was brought down to below 5. So here's a perfect example of a patient that as no sleep physician anywhere would suggest this is a good candidate for an oral appliance. And to dismiss somebody with these statistics, just because these statistics seem too difficult for an appliance, in today's day and age, is just not acceptable, because we have ways to test to ensure that the appliance will work before we proceed with therapy. This is the final efficacy report that I sent the physician once we were finished with this patient. Now, if we're dealing with a non-responder and they're PAP intolerant, this could be problematic. And here is why I say this. You can see here's 9 predicted failures actually responded to treatment. So you're telling them it's not going to work, but it worked. Okay? This is a problem, especially if they're PAP intolerant. And the other thing too is some of the 23 therapeutic failures may have actually been candidate for an oral appliance if used alongside some adjunctive therapy. Maybe there's some information we can be getting to give us some insight on this. Well, the good news is meaningful information can be obtained in a final static report, and when compared to baseline data, can provide insight as to whether the patient will respond enough to proceed with an oral appliance. So look at the raw data on the final static study. So on the theragnostic study, you have the active one, which is the first night, and then you have the static one, and then perhaps the third night. So either, whichever is the last study, whether it's the second or the third, that's the study you want to look at. You want to review ODI. You want to review body position. You want to determine if the ODI is improved from baseline, if the ODI is related to sleep position, and if the ODI is in clusters, indicative of perhaps REM-related apnea. So this patient, baseline of HI of 55.2, overall ODI of 50, okay, was labeled a non-responder by the Matrix Plus. And if we take a look at that last study in the theragnostic series, you had a supine ODI of 60.1 and a non-supine ODI of 51. So clearly, there's no indication here at all that you're going to be able to do much with an appliance. It's not, it's not a positional thing. It's pretty well all night long. He's desaturating with the appliance optimally positioned based on trying out various positions with the RCMP. Where you could perhaps help this patient is using the appliance in conjunction with their PAP so that the PAP can be delivered at a lower pressure. So combination therapy of some kind. But the appliance alone is unlikely to do much for them. Here we have someone with a baseline AHI of 73.9, overall ODI of 16.4. And we can see in supine position, he has an ODI of 53.9. Non-supine ODI of 9.3. So perhaps this individual, along with some positional therapy, right? Oral appliance and positional therapy could be helped, even though the Matrix Plus labeled them as a non-responder. Here we have a baseline HI of 52.3, overall ODI is 11.3. So we can see non-REM ODI, initial part of sleep, 6.9. Now, if we look the rest of the night, we see clusters. ODI 45.5, 33.1, 45.0, 20.6. Now, we're not measuring brain waves. So I have no way to officially determine that this is REM sleep. However, when we see these clustered together in the same level of frequency as when REM sleep would happen, this is indicative or suggestive of REM-related apnea. Okay. Significance of REM OSA remains controversial. Right? There's evidence on both sides of the fence on this in the literature. However, we know that severe REM OSA is associated with cardiovascular endpoints in those with prevalent cardiovascular disease. And we know that REM OSA is quite prevalent and associated with adverse cardiovascular and metabolic outcomes. So it's not something that we want to ignore. It's also important to note that 1/3 of PAP patients wear their PAP all night long. So we get the next third wearing it part of the night and taking it off, likely not wearing it at all during their REM sleep. And we got 1/3 not being able to tolerate it at all. So if somebody is PAP intolerant, it's still a problem. And even if somebody is semi-tolerant to PAP, it's still a problem. They're not getting the help they need. So what we have to consider for these patients, if the appliance alone cannot help them 100%. Perhaps combining the appliance with the PAP might be able to get them the help they need. So some caveats, because this is off-label use of the Matrix Plus, right? There's night-to-night variability. And we need to understand that looking at that last night study does not predict what will happen on another night. Okay? We can't compare what we've just done, this little exercise we've just gone through, with a machine learning exercise algorithm that evaluates 266 binary variables along with ODI. That's completely unrealistic. We're not trying to override that. What we're trying to do is look at the raw data and see if there's some information there that can help us make good judgment calls, especially for a patient that cannot tolerate wearing PAP. Okay? If you wish to evaluate it further, of course, there's a little TD clip where you clip the device together and they can wear the tray, much like you would be wearing the Apnea Guard, and have the patient wear it for a week, evaluate things objectively, then of course do an HST or a couple nights of HST to further substantiate before you actually move forward and make an appliance. These are the tools that are available to us beyond the on-off switch we know of as it works or it doesn't work that the Matrix Plus offers. This is off-label use, looking for patients that could benefit from oral appliance therapy, especially if they have failed PAP use. Thank you very much. At this point, we're supposed to be hearing the discussion which went on past 5 o'clock today, except I forgot to press the record button again. So I just posted these slides. This was the fodder that we were going to discuss moving forward. And actually the discussion was quite interesting. So it's unfortunate it didn't get, but you can make up for it by attending future episodes. Wednesday afternoons, DSMSpeakEasy between 3 and 5. And I'll try and remember to press that record button. Ciao.